Hi viewers and my dear loving students, good morning to everyone. Today we will see a topic that comes under midwifery and obstetrical nursing. This very well you know, last class, that is the last live session on Wednesday, we discussed the topic. Just think what was the topic? The topic is malpresentation. So we will today see the continuation of malpresentation part 2. So what we have discussed on that section, that is on the Wednesday, what is meant by malpresentation, what are the causes, and we have discussed detailedly about what is meant by breech presentation. So what is a normal presentation? I hope you know normal presentation, that is the vertex presentation is known as the normal presentation. Other than the vertex presentation, in the cephalic presentation, that is the face presentation, brow presentation, breech presentation, shoulder presentation, compound presentation. So these are known as the malpresentations. Once again, we'll revise what are the causes of malpresentation. So I told no causes you can remember like maternal causes, fetal causes, placental causes. And first we will see what are the maternal causes. Maternal causes of malpresentation. So maternal causes such as women having any problem during the pregnancy, like uterine malformation, uterine abnormalities, septate uterus, cornate uterus, any congenital malformation of the uterus, any fibroid or myomas present in the uterus. Such conditions they can get, and pendulous abdomen, hydromias, polyhydromias, oligohydromias, and mainly the reason is polyhydromias. Next one is lateral obliquity of the uterus, dextrorotation of the uterus. So that is a position. And another factors that comes under maternal is multiparous women. So why multiparous? So many childbirth they have given. This will lead to laxity of the uterine wall, abdominal wall, as it is known as the laxity of the abdominal wall. This is reason for the multiparity women. So these are the major causes of maternal reasons for getting the malpresentation. What are the fetal causes? More than one fetus. You know the condition, what is more than one fetus? That is multiple pregnancy. Fetal anomalies, any trisomies, like that chromosomal problems, and fetal congenital anomalies such as big head, like hydrocephalus, problem, and if the baby birth weight more than 3.5 kg, and the baby is having a fetus is having cord around the neck, or cord, you know, no umbilical cord around the neck. So there is any goiter, any tumor is present in the neck. So this leads to fetal causes. Next, we'll see placental causes. Placental causes, last class you remember what may be the major placental causes, that is placenta previa. It is one of the major placental causes, that is placenta will come and lie in the lower pole of the uterine. And another one is if we are seeing the breech, recurrent breech can happen, repeated. Previous pregnancy, if the woman have the history of breech, further pregnancy or present pregnancy also, she can have the history of breech. That is known as the recurrent type of breech presentation or malpresentation. So that class we discussed about breech. So what is breech presentation? Before going breech, we have discussed two things. No, one is lie we have discussed. Another one is presentation. What is presentation? The part of the fetus that comes and lie in the lower wall of the uterine segment. That is the presentation. So here in the breech presentation, the podalic pole, the buttocks will come and lie in the lower wall of the uterine segment. And we discussed about lie. What is lie? Lie, it is the relationship of long axis of the fetus to the long axis of the maternal spine. So here there will be a parallel. The long axis of the maternal spine to the long axis of the fetal axis will be parallel. That is known as the longitudinal. Lie will be longitudinal. In breech presentation, the lie will be longitudinal. The part of the fetus, that is the buttocks, will come and lie in the lower pole of the uterine segment. So this we have discussed about breech presentation, and we have seen about what is the incidence. Mainly 28 week, if you see 20 to 28% of chances for getting breech, because major cause is like prematurity. The baby will be moving inside the uterine cavity. This will come in a normal presentation with 36 or 37 weeks of gestation. In prematurity, babies are there, more risk. So 28 week and all having more risk for getting the breech presentation. Then later, when it does the term, if you see 3% of chance for getting the breech presentation, that is a major incidence. And we have seen the classification. What are the classification? Mainly breech presentation. Two classification is there. Complete breech is there. Incomplete breech is there. Complete breech, that is universal. Complete flexion of the fetal bodies. Relationship. Attitude means relationship of one part of the fetus to another part of the fetus. Here, complete breech involves complete flexions. That is, the upper and lower limbs will be flexed. The chin will be rest on the chest. So, like a snug position. That is complete breech. Another one is incomplete breech. Varying degree of extensions of limbs will be there. So here you can remember like frank breech we have discussed. Another one is then footling presentation, knee presentation. So these are the two types of breech, complete breech and incomplete. Incomplete under frank breech is there. Another one is footling presentation is there, knee presentation is there. Then we have seen about two types of clinical, according to the clinical features or clinical complication, complicated breech and uncomplicated. Uncomplicated, no complications will be there. Complicated breech, if the breech is having prematurity, placenta previa, multiple pregnancy, some of the causes leads to complication, then it is known as complicated breech. Then we have how to diagnose. Main thing you have to remember, frontal grip, what will be present? Hard globular, that is the head. Pelvic grip, what will be present? That is a soft, broader mass will be present. That indicates the podalic, that is the buttocks. Side we can see the limbs and the spine, and the FHRs will be upper part of the umbilicus. So FHR can be here nicely in the upper part of the umbilicus. So this will be different from frank breech, footling, knee, and the complete type of breech. And in the vaginal examination, we can easily find out what will be there if the buttocks is down. So we can find out the sacral parts. We can find out the anal opening, ischial tuberosity, and thick meconium can be assessed when we are doing the palpation. So this is the main thing we can see in the breech presentation in the vaginal examination. Next, we have seen about the management, antenatal screening, history collections, and if possible, external cephalic version if favorable circumstances. Unfavorable circumstances like central placenta previa, preeclampsia cases, multiple pregnancies. These and all absolutely we cannot do for external cephalic version. Then intranatal management, mainly three is there. Spontaneous expulsion of the fetus will be there with the minimal assistance in the breech. Assisted breech deliveries are there. Then breech extractions are there. And in the assisted breech delivery, first we have to deliver the buttocks and the trunk, then deliver the shoulder, and next we have to deliver the head. If the head is not delivered, to deliver the head, we have some maneuvers are there, assisting maneuvers are there. One is Burns-Marshall method, we have discussed. Second one is force of delivery, and third one is Mauritius-Melling method. And another one, if the limbs frank breech is there, Pinard maneuver is there. So we can apply the pressure on the popliteal fossa, update the leg, then bring down the each foot, and we can deliver the fetus. And the second one is if it is extended limbs, extended upper limbs, that is the hands. Then we can go with the extended arms. Then we can go with the maneuver that is known as classical maneuver is the low set maneuver is there. So femoropelvic grip, they have to hold the baby. That is, the baby will be hanging on the its own weight. We have to hold in a sterile towel. Femoropelvic grip. Our thumb fingers has to be parallel with the spine. Then the baby has to be rotated 180 degree till the anterior shoulder will be coming up. The posterior shoulder can be delivered. Same visa can be done. So this is known as the low set maneuvers. And unfavorable circumstances, we can obstetrician can decide for the elective or emergency cesarean section. So this we have discussed about in the breech presentation. So today we'll detailedly see about other type of presentation. So first we'll discuss about what is meant by face presentation. So face presentation, I told normal, you can remember cephalic presentation. What is cephalic presentation? When the head comes and lie in the lower wall of the uterine cavity. That is known as the cephalic presentation. That is the fetal part of the fetus. That is the head comes and lie in the lower wall of the uterine segment. Then it is known as cephalic presentation. In the cephalic presentation, the vertex that is coming and lying the lower wall, then it is known as the vertex presentation. Vertex is considered as the normal presentation. Another one is face presentation. So you can remember. So this is the fetal skull. So vertex part is the part between the anterior fontanelle and posterior fontanelle. So this part is known as the vertex. This is the normal. Actually, this has to come and lie in the lower wall of the uterine segment. If the face of the fetus come and lie in the lower wall of the uterine segment, then next it will known as the face presentation. So what is the lie of the face presentation? The lie of the face presentation is longitudinal lie only. The relationship of long axis of the fetus is parallel to the long axis of the maternal spine. So lie will be longitudinal. So why the face is coming? You just think why the face is coming. What is the attitude of the fetus? In the normal presentation, the attitude will be completely flexed. So complete flexion means what? So you remember, no? Complete flexions. In the complete flexions, what happened? So here the limbs will be flexed. Okay, so this is the fetal dummy. The limbs will be flexed and the head also will be flexed. So the chin will be rest on the chin. So this attitude is known as the complete flexions of the attitude. So when extension, the head will be extension. So when the head is extension, hyperextension of the head, then it is known as the face presentation. So usually flexion will be there. If it is goes as a complete extension, okay, so the neck will be extended, then it is known as the hyperextensions of the head. So that will leads to the presentation of face presentation. So like this, the fetus will be present inside the lower wall of the uterine cavity. So this type of presentation is known as the face presentation. That is hyper extensions of the neck. So what are the incidents of getting face presentation? So face presentation, 1 in 500 labor time, we can see the face presentation, 500 or to 800. So this ranges, we can see the face presentation. It is the rare form of presentation that we can find out in the labor period. So lie will be longitudinal and the presentation will be face presentation. So what are the causes of face presentation? So attitude here, there will be hyperextensions of the neck. So here, what are the causes? Why the hyperextension is happening? So you can think hyperextension. What are the causes for getting hyperextension? So fetal causes, you can see cord around the neck. That is the tangled cord. So umbilical cord is around the neck. So the fetus cannot be flexing the head. So that is one of the causes. Any type of tumor, that is thyroid gland enlargements. So like that, if they are here also the fetus cannot go for flexion. And so if they having any stiffening of the neck having any congenital problem, stiffening of the muscles, then also they can go with flexion of the flexion of the head. So they will leads to the hyperextension only. So these are the major causes of fetal. Maternal causes, same like malpresentation, laxity of the abdomen, multiparas, and lateral obliquity, that is the obliquity of the abdomen, and they have any polyhydramnias. So this pendulous abdomen, these causes they can leads to face presentations. Are clear? No? Then we will see what are the positions of face presentation. Face presentation mainly here what is the denominator coming, that is the bony, arbitrary bony fixed part that will come and lie in the maternal quadrant, different parts of the maternal quadrant, that is known as the denominator. So the what will be the denominator? Denominator is mentum. What is meant by mentum? Mentum is otherwise known as chin. So the mentum will come and lie in the different quadrant of the maternal pelvis. So if the mentum is coming and lying in the anterior part near to the symphysis pubis, then we can tell us the left mento anterior or right mento anterior. If it comes behind in the sacroiliac joint, then it is right mento posterior and left mento posterior. So here we can mainly the commonest we can see is that is the left mento anterior. So left mento, how the fetus will be lying, flexions of extensions of the head, the spine also having the extension. So next we will see what is the mechanism in the face presentation. So mechanism I told no. So commonest position of left mento anterior, it is the commonest position. So chin it is known as the mentum. So face presentation, chin is otherwise known as mentum. So the chin is the leading part here. So you all remember the principles of mechanism of labor. First one is descent takes place throughout the labor. Whichever part which comes and meet the pelvic resistance will rotate one edge of the circle anteriorly and comes under the symphysis pubis. Whichever parts moves under the pelvis will pivot around the pubic bone. So these are the three principles of mechanism of labor. So which is the leading part here? So leading part is mentum, it is the leading part here. So the mentum will comes and lie in the left iliopectial eminence and the glabella will lie in the right sacroiliac joint, that is the oblique diameter of the maternal pelvis. So this here mentum, it is the leading part which will touch as the iliopectial elements first. So what is the diameter? Submentobregmatic. Submentobregmatic is 9.5 centimeter. So this will rotate one edge of the circle and comes under the symphysis pubis. So this is the anterior part of the pelvis. So here you can see the symphysis pubis. So here it will rotate one edge of the circle and comes under the symphysis pubis. So here according to the first principle, descent takes place. With the continuous descent, comparing to the normal mechanism in the vertex, here extension of that will be happen, extension of the head. So there we will study as a flexion. So here you can see the extension will takes place. Increased descent, extension will be taking place. Then next internal rotation. So the mentum will come under the symphysis pubis. So here the mentum will extension has to be taken. So here the mentum will be escape under the symphysis pubis. Here the face, brow, face and the will be delivered with the movement of flexion. So after the delivery of the head, what happened? The face will be going with the restitution. So it will be facing the opposite direction of the maternal thigh to relieve the twist that is formed on the internal rotation. And after that, internal rotation of the shoulder. So now the shoulder is lying in the opposite oblique diameter. So the shoulder has to rotate one edge of the angle and comes under the symphysis pubis. So anterior shoulder escape under the symphysis pubis, posterior shoulder sweep beneath the perineum and whole body delivered as a lateral flexion. So here according to a normal mechanism, here you can remember like extension, flexion component you can remember like an extension. So engagement, descent, extension, internal rotation of the face. So here what happened? Twist is formed. Then next delivery of the face with the movement of flexion. Then next restitution, internal rotation of the shoulder along with the external rotation of the head. Then next delivery of the shoulder and delivery of the trunk. So these are the cardinal movements that takes place in the face mechanism of labor. Next we will see how we can diagnose the face presentation. So diagnosis of the face presentation mainly, first this presentation mainly we can see on the labor period. Antenatal we can screen any risk for malpresentation is there. So during the labor time we can identify the face presentation. So here what happened? Abdominal examination. So near to the term, when we are doing the abdominal examination, we can see the appearance of the abdomen like S-shaped abdomen. So when they are having a skillful in identifying the abdominal examination, with the inspection they can identify. And a groove is formed between the sinciput and occiput. So here they can find out below the umbilicus. And when we are palpating in the fundal part, the broader area will be there, that is the vertex. In the lower part, head will be present, but it is not engaged, and it will be much broader will be there because non-engagement of the head. So that we can identify. And next in the vaginal examination. So vaginal examination, because the face is there. So face is there. When we are putting the fingers, you can identify the mouth can be found out. So mouth can be found out. When the fingers is going inside, sucking movement can be found out. Malar bones can be identified. And here you can see the alveolar ridges inside the mouth, alveolar ridges. So the malar bones and the mouth can be formed like a triangle manner. So that we can identify in the vaginal examinations after the rupture of membrane. So you can remember this is the face. So if it is the breech, anal opening will be there. If it is the face, you can find out the mouth will be present and the sucking movement and will be present. So these are the major differences in the breech and the face presentation when we are doing the vaginal examination. Next, what is the management? So management mainly in the first stage of labor as for the vertex presentation, same management only. If the favorable circumstances is there, adequate pelvic is there and adequate fetal size is there, first stage of labor can be monitored, partograph can be maintained, uterine contractions, descent and extension of the head can be identified with the help of vaginal examination, and whatever thing we have to record in the partograph. And fluids and electrolyte balance has to be maintained to prevent the dehydration, to notify any prolonged stage of labor, first stage or second stage of labor, any obstructed labor is there. So we should see whether it is a face presentation. Don't do any blood collections or analysis because face is there. If any baby is risk of fetal distress is there, that we have to identify. Continuous fetal monitoring to find out any FHR variation. FHR tracing has to be done, and we have to get the cooperation of mother if they are going with a vaginal delivery. And vaginal delivery with spontaneous expulsion is there. With carefully we can conduct the vaginal delivery. If any unfavorable circumstances is there, then they can go with a cesarean section. Mostly face delivery can go as a vaginal delivery, and needed forceps can also be applied according to the need of the obstetrician. What are the complications of face delivery? So face is present in the vaginal orifice. So bruising of the face, any rashes can be formed in the face because the face can be present in the pelvic region for long period or vaginal region. So they can get the edematous, bruising or facial injuries can be happen. So very carefully we have to conduct the vaginal delivery. So this comes under the face presentation. Next we will discuss about another condition that is known as the bro presentation. So bro, where the bro will be coming, bro is one of the another type of cephalic presentation. Cephalic means head is comes and lie in the lower pole of the uterus, that is known as the cephalic. In the cephalic presentation, when the bro comes and lie in the lower pole of the uterine segment, then it is known as the bro presentation. So you all know the fetus skull, no? So where the part bro is there, that is the part between the glabella and the anterior fontanelle. Anterior part of the anterior fontanelle. So this part is known as the bro. So when the bro comes and lie in the lower pole of the uterine segment, then it is known as the bro presentation. So cephalic presentation, what are the three varieties are there? One is vertex presentation. Vertex, it is the normal presentation. Then we have seen about face presentation. Then another one is bro presentation. When the bro comes and lie in the lower pole of the uterine segment, then it is known as the bro presentation or forehead. So bro, what is there? Frontal bone is there and frontal sutures are there. So that can be identified in the vaginal examination. So bro presentation 1 in 800 to 1000 deliveries we can identify the bro presentation. So bro also one of the complicated malpresentation that happens during the labor. What are the causes? Causes of bro presentation same as the malpresentation, like lateral obliquity, laxity of the abdomen, multiparous women's, and fetal any congenital causes that can lead to the bro presentation. What is the lie? Lie, it is the longitudinal lie is there. Presentation will be the bro. Here how the bro is formed means neck vertex presentation, complete flexion will be there. Then next in face presentation, hyperextension will be there. Here moderate extension will be there. So not complete extension, moderate extension. When it is in a moderate extension of the head, then it is known as the bro presentation. So bro presentation during the labor time, anytime the bro can be changed to vertex presentation and it can come like a normal vaginal delivery, or it can go as a face presentation like complete extension. When complete extension, occiput will touches the spine behind. So complete extension can happen and it can go as a face to pubic presentation if it is in an anterior presentation, anterior position. If it is in a posterior position, very difficult, arrest can be happen, long rotation very difficult will be there, then they can go as an obstructed labor. Okay, so this is the main thing you can remember in the bro presentation. Bro presentation, it is an attitude of moderate extension will be there. Anytime this can go as a complete flexion, as go as face vertex presentation, complete extension, it can go as a face presentation. And what is the diameter? Diameter, this is a MCQ's questions will be happen in the bro presentation. What is the diameter? So you all can remember that is Mendo vertex. Mendo vertex, it is the highest diameter. So this is the chin, that is the vertex, highest point of the vertex, that is Mendo vertex, that is 13.5 centimeter. So this 13.5 centimeter, it is the longest diameter of the fetal skull. That is MCQ's question. So this diameter will comes and lie in the pelvic inlet. So what happened? There is no mechanism of labor in the bro presentation. Mechanism of labor will be obstructed. No mechanism will be there. If Mendo vertex is there, they can go with a cesarean section to deliver the baby. Otherwise, that labor will be going as obstructed labor. So that you can remember. So what is a nurse? We have to monitor the mother during this first stage of labor, and there doesn't have any descent of fetal head, any obstructed labor is there. They can identify with the vaginal examination. So what is there in the vaginal examination? What will be there in the vaginal examination if it is a bro presentation? Frontal bones, frontal sutures, orbital ridges. So you can remember like this is the frontal bone, frontal suture, orbital, orbit है ना eye socket. Beyond the eye socket, orbital ridges will be there, glabella will be there. So this part can be palpated in the vaginal examination. And no descent of the head, then we can decide this is the highest diameter Mendo vertex, that is bro presentation will be there. Then surely it can go as an emergency cesarean section. So this bro presentation can lead to obstructed labor, even premature rupture of membrane can be happen, and dehydration, ketoacidosis for the mother, because prolonged delayed labor process will be there. So this has to be crucially monitored and has to be recorded, and LSES can be done to save both mother and the fetus. So this you can remember, that is known as the bro presentation. Next we will see another presentation, and next one is shoulder presentation. Shoulder presentation. When the shoulder will come and lie in the lower pole of the uterine segment, that is known as the shoulder presentation. So here presentation I told shoulder is there. What will be the lie? In cephalic presentation, the lie will be longitudinal. So other than longitudinal, we have discussed about two type of lie is there. One is oblique lie is there, another one is transverse lie is there. So what is meant by transverse lie? When the long axis of the fetus will lie perpendicular to the long axis of the maternal spine, that will form a 90-degree angle. Then it is known as the transverse lie. oblique lie when the long axis of the fetus lie diagonal to the long axis of the maternal spine. Then it is known as the oblique lie. When that will form like a 45-degree angle. So this transverse lie and oblique lie, when this lie is there, then the baby can go with the shoulder presentation. So you can see this is the pelvis is there and this is the fetus. So what is the normal line? Normal line, this is the podalic pole, this is the normal line. Okay, so this is the parallel to the fetal axis. Long axis of the fetus is parallel to the long axis of the maternal spine. If it is perpendicular, so long axis of the fetus is perpendicular to the long axis of the maternal spine, then it is known as the transverse, or diagonal, then it is known as the oblique line. So any this type of line, what happened, the shoulder can come and lie in the lower pole of the uterine segment. So then it is known as the shoulder presentation. So in the shoulder presentation, dorso anterior is there, dorso posterior is there. Left dorso anterior, right dorso anterior, left dorso posterior, right dorso posterior. So like that different positions can be happen. So this shoulder presentation, 1 in 200 pregnancies we can see the shoulder presentation. So what are the causes? Same like malpresentation only, causes that is present in the shoulder presentation. So mainly the relaxed abdomen, laxity of the abdomen, lateral obliquity, hydromias of the abdomen. So this can cause as a shoulder presentation. Contracted pelvis is there, flat pelvis is there, leads to shoulder presentation. Next we'll see what is the diagnosis, how we can diagnose the shoulder presentation. So shoulder presentation, it is like a oblique lie or transverse lie will be there. So what happened here, by seeing the abdomen, in the abdominal examination, by seeing the abdominal, we can identify irregular body parts will be there for the fetus. So normally the ovoid abdomen will be there, the abdomen will be broader for the transverse lie or the shoulder presentation. And when we are going with the palpation in the abdomen, that is a fundal grip, you see upper part, no fetal pole will be there, no podalic pole or no cephalic pole will be present. Head or buttocks will not be present in the fundal part. Same like that pelvic part also, it will be broader. Side, when we are seeing the left lateral or right lateral, there we can identify any one side hard globular mass, that is round mass, that is indicate the head, or soft broader mass indicates the podalic pole in the side of the maternal pelvis. And the variation of fetal heart in dorso anterior and dorso posterior, below the umbilical level FHR and above the umbilical level FHR can be heard. So this is the major findings we can see in the abdominal examination. So you all can remember. So upper part empty, lower pole also empty, fundal grip empty, pelvic grip empty, and lateral parts we can identify the fetal head and the podalic pole. Next we will see vaginal examination. What we can find out in the vaginal examination. In the vaginal examination, when we are identifying what is there, that is the feet shoulder can be identified. So the scapulas can be identified in the vaginal examination. So that is the major, no mouth or no anal opening or no vertex or bones, we cannot find out fetal head bones, skull bones. So here we can find out the shoulder. So this is the major difference in the vaginal examination. What is the management? We have to see what is the gestational week of the fetus, whether prematurity is there, what is the weight of the fetus, and what is the FHR, what is the maternal conditions. The shoulder presentation has some of the serious complications. Like maternal, they can go with exhaustion, dehydration, ketoacidosis, obstructed labor, uterine rupture, like that complication can happen. Fetus also perinatal mortality is higher, and same like the two problem will be there. One is cord prolapse and another one is limb prolapse. The shoulder is there, particular limb can come and prolapsed. It can come out and it will form like a gangrene can be formed. So that is limb prolapse can be happen. So nowadays, when we are giving a proper surveillance in the labor, we are identifying earlier and we can reduce this type of perinatal morbidities for the fetus. So here what happened, our thing whether the fetus is live or fetus is dead. Fetus is dead if obstructive, that is destructive procedure can be done and deliver the fetus. If that also not possible, can go with the cesarean section and deliver the dead fetus. If the fetus is live, cesarean section and deliver the fetus. If some favorable circumstances is there, the shoulder they can go with the rectification or version, spontaneous version can be happen, and this can be delivered through the vaginal delivery. Vaginal delivery also possible if it is prematurities or size of the fetus is less and favorable circumstances. So this is the major management that comes under the shoulder presentation. So you all can remember the main complication is prolapse of the arm and prolapse of the umbilical cord. This is the main complications comes under the shoulder presentation. Next we will see about what is meant by compound presentation. What is meant by compound presentation? Compound or otherwise known as the complex. More than one part of the fetus that comes and lie in the lower pole of the uterine segment. So along with the head, if any limbs is there. Along with the breech, if any limbs, upper limb or lower limb present at the lower pole, then it is known as the compound presentation. So 1 in 600 pregnancy and we can find out the compound presentation. So compound presentation also same causes like a malpresentation only. We have to see what is whether prematurity is there, what is the gestational week of the mother, and any other complications is for the mother, like multiple pregnancies are there, or the mother is having hydromnias problem is there, or fetal anomalies is there, that we have to identify. So this compound presentation, prematurity less than 37 weeks, severe prematurity, favorable circumstances, adequate pelvis is there, then they can go with a vaginal delivery, and newborn care has to be taken. Preterm newborn care has to be taken. It is a normal pelvis, adequate fetal weight is there, compound presentation, complicated compound presentation is there. Surely they can go with the elective LLCS by seeing the scan. So this comes under the compound presentation. And last one is unstable lie. So what is meant by unstable lie? Lie, I told lie. What are the there is a relationship of long axis of the fetus to the long axis of the maternal spine. Lie usually longitudinal lie. Lie, other type of lie is transverse lie is there, oblique lie is there. So the fetus inside the uterus will be moving or rotating inside the uterus. Movement is very much needed. If any congenital anomaly is there, the baby will not be moved properly. Meningocele, meningomyelocele, nerve impulses will not be there. Movement will not be there. There will be particular presentation only. If the baby is normal growth inside the fetus, normal fetus has to be moved inside the uterine cavity. So then it will attain 36 to 37 weeks in a normal presentation. That is the cephalic presentation, vertex presentation. Some unfavorable circumstances like birth weight is, the weight is less, IUGR babies or prematurity, the baby will be again chances there to moving, or the mother condition like polyhydramnias, pendulous abdomens, lapsed abdomen, lateral obliquity of the uterus. So this causes what happens again after 37 weeks also the movement will be there for the fetus. Anytime the lie can be changed, then it is known as the unstable lie. So here we can diagnose abdominal examination and we can see the ultrasonography, what is the type of lie, and the obstetrician can decide, mostly they can go with the cesarean section, or antenatal they can go with external cephalic version during that term, and unfavorable circumstances, then they can go with the normal vaginal delivery if the favorable circumstances is there. So this is known as the unstable lie. Last we'll see about what is the nursing management, that is comes under the malpresentation. So very important, no? Nursing management. As our nurses, we have to assess the pregnant women during the antenatal period. What is the major risk? So you all remember causes like maternal causes, fetal causes, placental causes. Placental causes, what is the placenta previa? So we can see all this thing in the scan. Hydromnias is there, any congenital anomalies are there, multiple parous women are there, multiple pregnancies are there, polyhydramnios are there, pendulous abdomen are there. So histories, how many children already the women have, how many abortions, laxity of the abdomen. So antenatal, we can see the histories, and in the ultrasonography inference, we can come to a note, this women are having malpresentation. So breech in cases already first child that they have go with breech. So second child getting, so in our mind it should come, this is type a recurrent type of breech is there. If the baby is having any congenital anomalies, trisomies, hydrocephalus, then the fetus also having causes. If the baby is having thyroid gland enlargement, twist around the neck, then we can find out this is go with the face presentation. Then in the labor, we can identify labor. So during the labor time, first stage of labor, second stage of labor, it is crucial for the nurses to monitor the partograph. Partograph is very much essential. We can identify any dystocia is there, difficult labor is there, any abnormal uterine action, any difficult obstructed labor is there. So here we have to see what is the descent of the fetal head, what is the cervical dilatation, whether prolongation, duration of labor is lengthy or not. First stage, whether it is going for lengthy duration. Second stage also it is going for lengthy duration, that we can identify. So prolonged stage of labor. So here how the descent of fetal head. Any malpresentation is the descent of fetal head will be difficult. Cephalopelvic disproportion. Maybe of contracted or flat pelvis. So this we can identify. And in the abdominal examination, when the nurse is doing, each presentation will be different. So breech presentation, we can identify the podalic pole and the lower pole of the uterus, and in the cephalic presentation, different is there. During the vaginal examination, we can identify the face presentation with the mouth opening. So we can identify the eyes, we can touch the nose, we can touch the alveolar ridges, malar bone, all in the face presentation, sucking effect of the face. In the breech presentation, thick meconium can be touched in our fingers, and anal opening will be there, ischial tuberosity, this will be formed like a line. In face, it will form like a triangle. So this vaginal examination, clearly we can identify this is breech, this is face, and bro. Bro means frontal sutures, orbital ridges, frontal bone can be identified. Shoulder means scapula, shoulder, that can be identified. So this vaginal examination finding has to be clearly taken and reported. We have to record, and whether if it is emergency cesarean section or is there, we can prepare the mother for the cesarean section. And third one is the nurses has to be energetic effort to give care during the malpresentation. So complication, I told the women can go with ketoacidosis, dehydration, obstructed labor. There is more chance for getting uterine rupture also due to obstructed labor. So this has to be monitored for preventing the dehydration, ketoacidosis, fluid electrolytes balance has to be there, bladder bowel care has to be done, left lateral position has to be maintained, monitor properly, blood investigation has to be taken. We have to find out when a RH negative woman is there. So we have to prepare for administrating Rogam injection. So this has to be done. And they are more risk for getting increased operative deliveries like forceps delivery and cesarean section. So this keep in mind and ready for the operative deliveries. Then next we have to give a consent, because most babies are prematurity, perinatal asphyxia will be there, birth injuries, the babies can be happen, and the baby's perinatal mortality is higher in breech presentation like that, and cord prolapse also complication. So our thing getting concerned from the family members and from the patient is very much essential. So the labor period, anything can be happen, the consent has to be taken, and psychologically we have to prepare the woman for if favorable circumstances vaginal delivery and another thing. And another one is in the antenatal period, any woman goes for external cephalic version, that also we can get the consent, and we have to prepare, arrange the topolytic drugs and ultrasonography measures to assess the obstetricians. And during the operative deliveries, we have to assist it with the obstetricians, and delivery has to be done. And we have to inform the neonologist, arrange all the articles to receive the newborn babies, because malpresentation commonly we can see the prematurity babies, preterm babies. So preterm care is very much important, and operative delivery sometimes they can go with any risk of injuries. So that has to be monitored, like shoulder dystocia, any prolapse can be happen, cord prolapse or cord around the neck, the FHR variation will be there, cord compression can be happen, the baby can go with asphyxia, neonatal, decreased absence of taking respiration. So they all need neonatal resuscitation like that. So that measures also we can practice. And another like a role as a nurses, as for the students or for who are working in the labor ward, we have to give a simulation how this maneuvers are conducting. Breech delivery, how it will be conducting, how to monitor, how to conduct the mechanism, or how to conduct the labor, how to assess the deliveries. That practical sections can be conducted in the ward and give a train for the midwife. This will get a confidence and skills will be attained to prompt identify the high risk malpresentation cases, and they can conduct in the labor in a very good manner in the labor. So these are the major measures that comes under the nursing management. So they have to find out the complications. So complication already I told, mother, what are the complications? Complication like maternal dehydration, acidosis, uterine rupture, obstructed labor, inertia can be happen, different inertia, premature rupture of membranes. So these are the major complications for the mother. What are the complications for the fetus? Perinatal mortality, death is higher, cord prolapse can be happen, prolapse of the arm can be happen, any injuries, fractures can be happen, facial injuries, nerve injuries can be happen for the fetus. So these are the major complications, that is asphyxia neonatal. These are the major complications that comes under the malpresentation. So I hope today topic you are clear. So we have seen about what is malpresentation, what are the different types of malpresentation, what are the incidents, what are the causes of malpresentation. So what are the types of malpresentation? One is vertex presentation is the normal, other than vertex, that is face presentation. The next one is brow presentation. Then we have seen about breech presentation, shoulder presentation, compound presentation, and unstable line. So you all can watch our live sections from this channel, and latest updated videos from our channel rjcsk.edu, and you can subscribe our channel, and you can press the bell button, you will get the notification. Thank you.